Hello, my name is Charles Snyder. Dr. Craig Lillehei and I are the co-chairs of the Professional Development Committee, or PDC. A brief background of the PDC. The committee is charged with multiple tasks, and these include the biannual creation of about 80 questions for the expert platform, now used by the majority of the APSA membership. This now has about 1,600 questions on the platform with multiple choice answers and discussions regarding the correct answer and why it is correct. Spaced learning, most of you are familiar with the Sunday emails linking to 2 questions from the expert platform with a recent addition of a visual abstract from Dr. Stephen Lee in the Educational Committee. Spaced learning materials are repeated to reinforce the teaching points. Articles of interest. Each of the APSA clinical committees selects content-specific recent articles which are felt to be important and worthy of dissemination to the readership. These articles are reviewed, they're curated, and then highlighted by the PDC in order to decrease email overload and duplication. Probably the most important task is that of identifying knowledge gaps and new information for the membership. The committee creates a yearly top 10 list, and from this list, 4 TEC Talks, or top educational content talks, based on the popular TED Talks, are identified, and in collaboration with the APSA committees, speakers with topical expertise are selected. The top 10 list is then distributed through other channels as well, such as the expert questions, the spaced learning, the annual stay current course, social media, and many other venues. Collaboration with other committees is critical to all of this. We rely on the other committees to leverage their knowledge and content expertise in identifying and creating these knowledge gaps and other areas of production. The recent creation of a committee of chairs, which incorporates all APSA committee chairs under the direction of Dr. Casey Calkins, is a welcome addition in this regard. And again, in conclusion, we ask you, the listeners, for assistance with identifying these knowledge gaps, and we encourage you to contact any of our PDC team with topics you feel would be of interest to APSA members, or areas which your practice identifies as clinical dilemmas or areas of controversy. Thank you.
Thank you, Chuck, for an excellent summary of the Professional Development Committee's activities and partnerships. It's my pleasure to introduce the speaker for our first APSA 2021 TEC Talk. Dr. Beierle is Professor of Surgery and Pediatrics at the University of Alabama in Birmingham and the Children's of Alabama Hospital. She's also a most active and energetic member of our PDC. Her charge is to review the 4 top educational content topics of 2020 and reinforce the lessons to be learned. Liz, the podium is yours.
Hi, I'm Elizabeth Beierle. I'm a member of the APSA PDC, or Professional Development Committee. On behalf of the committee, I'd like to thank you, our members, and the APSA leadership for your enthusiastic support of these talks over the past couple of years. And I'd like to welcome you to the 2020 TEC Talk tidbit, or T to the 5th. It is my charge to provide you with a brief synopsis of the talks from last year to help us remember through repetition what we learned. So the first talk last year was given by Dr. Matthew Harding, and his talk was on protocols for the care of children with congenital diaphragmatic hernia. Dr. Harding started his talk with this slide. And on this slide, the question relevant to this slide is, when is the best time to repair congenital diaphragmatic hernia on ECMO? And as you can see from the slide, their answers are extremely varied. In fact, they're so varied that it would be hard for any of us to look at this slide and say which therapy is the best. So Dr. Harding challenged us to potentially take an alternative pathway to how we study congenital diaphragmatic hernia. He pointed out that currently there are about 18 reports in the literature of clinical trials with congenital diaphragmatic hernia. The problem with clinical trials from his standpoint is that the enrollment numbers are low. So the mean average patients in these studies was about 28. It takes a long time to complete a clinical trial. They're expensive. There's problems with patient recruitment and attrition. And you can only answer one question. So his idea was that we should have patient-designed protocols and guidelines for the care of congenital diaphragmatic hernia and study congenital diaphragmatic hernia through those guidelines. Now, there's a precedent for clinical guidelines in pediatric surgery. We have a lot of them for appendicitis. As far as congenital diaphragmatic hernia, there are clinical guidelines that exist currently in Europe and in Canada. So Dr. Harding really wants us to think about using the alternative pathway, or challenge us to use the alternative pathway to study congenital diaphragmatic hernia using these clinical guideline protocols. Our next talk was by Dr. Todd Ponsky, and he talked about neonatal gas embolism. His talk can be summarized with this slide. The slide shows recognition, prevention, and treatment. So Dr. Ponsky was talking about recognition, not necessarily in the fact of recognizing the symptoms, but actually recognizing that neonatal gas embolism is a real entity. We may not have heard about it because it's clearly underreported in the literature, but it does exist. Based on that, we should learn how to prevent it. He provided us with some mitigating factors that could help us prevent neonatal gas embolism, based on the fact that the reason this occurs is probably because there's a small bit of damage to the umbilical vein, or the trocar is actually put into the umbilical vein, leading to an introduction of gas into the venous system. So his mitigating ideas were to put the incision in the umbilicus away from the umbilical vein in the infra or supraumbilical location. He also recommended that you put the camera into the trocar and look to be certain that you're in the abdomen prior to insufflating the abdomen. And finally, he recommended bleeding the gas line with CO2 prior to hooking it to insufflation. As we all know from physics in high school, CO2 is much more soluble in gas than nitrogen. So if you get rid of the air and the nitrogen from the tubing and replace it with CO2, the chances of having a gas embolism are smaller. His final part of his talk was on treatment. So basically, you want to get the air bubbles back into the heart, away from the pulmonary artery. So immediately put the baby in Trendelenburg position, left lateral decubitus position, head down, right side up. This will cause the air bubbles to come back into the heart. There are some reports in the literature of actually putting a catheter into the heart and sucking out the air bubbles. But oftentimes, these babies will actually need to go on emergent ECMO, so you should be prepared to do that. Basically, the treatment, as far as Dr. Ponsky was concerned, was prevention. Our third talk last year was provided by Dr. Jason Fisher, and he gave us a talk about the use of biologics and the management of inflammatory bowel disease. Basically, Dr. Fisher explained to us that biologics are antibodies, and they primarily, for the treatment of inflammatory bowel disease, are directed towards cytokines or integrins. They have become the frontline therapy for inflammatory bowel disease, both Crohn and ulcerative colitis. The thing that he focused on were the questions that surgeons have. So one of the questions that surgeons have related to biologics in inflammatory bowel disease is, will these supplant the need for surgery in inflammatory bowel disease? And his answer to that was basically no. So it looks as though the use of biologics in Crohn disease improve the intraluminal disease process, but probably don't change the need for surgery. It may change the need for recurrent or surgery for recurrence, but probably the patients are probably still going to need to have surgical interventions for things like stricture or perforation, that sort of thing. As far as ulcerative colitis goes, again, it doesn't look like biologics will supplant the use of surgery, but it may prolong the amount of time that the patients have before they need to have surgical intervention for ulcerative colitis. Another common issue that surgeons face is, do the use of biologics preoperatively have an effect on our patients postoperatively? And again, Dr. Fisher pointed out that the data here are probably mixed. So a recent study presented at Digestive Disease Week showed that the risk for postoperative infection was not increased with the use of preoperative biologics. Another study showed that other postoperative issues such as stoma dehiscence may be increased with the risk or with the use of preoperative biologics. So the jury is out on that one. When can we as surgeons tell our colleagues in GI medicine that it's okay to restart biologics after surgery? Most of the data would indicate that probably 4 weeks post-op is an adequate amount of time to allow them to restart their use of biologic therapies. The final part of his talk was basically addressing perianal Crohn disease. So he told us about a study that was done at Cincinnati Children's Hospital. And in this study, they evaluated all the children that came to the emergency room with a perianal abscess. And what they found is that children, male, older than the age of 10, with a fistula, probably if they have an abscess, this is their first onset or their first clue that they have early onset Crohn disease. And those patients need to be treated differently than the other child that just may have a perianal abscess. He further provided information about treatment for perianal Crohn disease and provided some data to us showing that the use of biologics with aceton was superior to the use of either alone in the rate of fistula healing, the time to fistula healing, and the time to fistula recurrence. Very great information. The final talk was provided by Dr. Kathleen Van Leeuwen, and she talked to us about gonad preservation and complete androgen insensitivity syndrome. She challenged us to challenge the dogma. Well, what did this mean? So complete androgen insensitivity syndrome is a subset of children with 46XY differences in sexual development. This is the most common of the 46XY DSDs. These children are complete androgen sensitivity. So they are phenotypically girls. And they're usually not diagnosed until they are in their teen years and they start getting worked up for amenorrhea. And they're found to have intra-abdominal testes. The reason that she wants us to challenge the dogma is because most of us were taught that these children need to have a gonadectomy to prevent them from getting cancer. The data actually show that the risk of cancer is probably only somewhere between 0.3 and 8% by 25 years of age. The thing about these gonads is they don't just secrete estrogen, they secrete a whole milieu of hormones that make that young lady feel like who she is. And children that have gonadectomy with this issue have a hard time after gonadectomy because it's almost impossible to replace those hormones in the same milieu that they are in the natural state. So Dr. Van Leeuwen contends that we should allow the patients to decide what to do. And once they decide what to do, we should support them, but make them responsible for their care. So if they choose to have a gonadectomy, Dr. Van Leeuwen recommends that that be done laparoscopically. If they choose to keep their gonads, she recommends that they take responsibility for their follow-up because the follow-up is significant. She recommends an ultrasound every year and a pelvic MRI every 5 years. Again, challenge the dogma. These were our great talks last year. Thanks for joining us today for a brief review of last year's TEC Talks. This upcoming year, I hope that you will join us for the talks that we have in store for you this year. We're going to have Rob Russell talk to us about new ideas and new guidance for trauma resuscitation. We will have Hannah Piper is going to give us a presentation on improving outcomes in intestinal failure. Dr. Chris Weldon is going to speak to us about cancer as a chronic disease. And finally, we're really excited to have Maria Cho, who will be our first parent, give a TEC talk, and she's going to give us some insight on family-centered care. Enjoy the rest of the meeting and have a great day.